So let me introduce you, Marguerita, briefly, then you can elaborate. So just to say that tonight at 8 p.m. apparently at the Commonwealth Club, there's a talk, maybe you heard about this from some international expert, on reaching youth through social media. And you don't have to go, because we're having the talk here. The Commonwealth Club is here at CVP. Marguerita Lightfoot will be talking to us about engaging youth in the digital age. Marguerita, I've known, not very well, maybe superficially at a number of Department of Medicine events, and like many of us, started from very humble beginnings and has had a sort of meteoric rise. She now is both Chief of the Division of Prevention Science in the Department of Medicine and Director of the Center for AIDS Prevention Studies, CAPS. And for those of you who were not here for the beginning of the AIDS epidemic, I cannot overstate how important CAPS was to our understanding about health behavior with respect to sexually transmitted infection, communicable disease behaviors, and interventions to prevent the spread of HIV. CAPS is a remarkable interdisciplinary research center, a real a model for UCSF, and I think in many ways CVP is attempting to emulate that. What else can I say about her? She has background work in psychiatry. She's been very interested in behavioral interventions, particularly around AIDS, but not exclusively in AIDS, and has received numerous awards, including the one that I like the most in your list here, the Anne Rosenfield Distinguished Community Partnership Prize. So I look forward to being able to collaborate with her on a personal basis, and for us here in our center to work more closely with her and with CAPS in general. And I don't know if there's anything I left out that you want to add in?
That was great.
Okay, good.
Thank you. So I'm hoping, so what I'd like to do today is share with you a body of work that I've been working on for a long time. I won't even say how long, because I don't want to be dating myself. Although as I go through this technology and you see me attempt to use it, you'll see just how old I am. And so to start off with, let me kind of give you a context for why I'm doing the work that I'm doing and in the area that I'm doing. So as Dean alluded to, a lot of my work has been HIV prevention, but really more sexual health, more generally. And there's a couple of reasons why that has been. So first of all, we know that although there's still vast parts of the country that like to deny it, young people have sex. And eventually, we all will have sex at some point. And so it's really nice to try to educate folks about how to do that safely and relationships and all of that stuff while at the time that you're beginning to learn how to do that and navigate that. And so this is some data from the CDC's national data set that basically speaks to the fact that young people are having sex. Almost half of 9th to 12th graders report having sexual intercourse. So that's going to be vaginal or anal intercourse. And if you looked, and this is 9th and 12th graders, so if you looked at just the 12th graders, the numbers would be closer to something like 75%. So a large number of young people are having sex. And meanwhile, they're not using condoms or as much as we'd like, right? So although this number is going up and we're seeing unplanned pregnancies going down, so we're having some successes, there's still a large number of young people who are not using a condom, at least, at their last time that they had sex. And the reason a condom would be most important, as you know, would be to prevent sexually transmitted diseases and infections, including HIV and a number of others. And so because of this, we're seeing kind of the impacts are great. Although we're seeing decreases in the number of pregnancies, we're still seeing a whole heck of a lot of unplanned pregnancies and live births among teens. Many more than we would like. Young people are probably one of the highest populations getting sexually transmitted infections. And if you look at HIV rates globally, half of them are going to be with young people under the age of 25. So let me hone in a little bit on HIV as a reason why I do HIV prevention work in particular. And that is that globally there are, it's a devastating epidemic that's impacting a large number of people, and particularly young people. And if you look just in the United States, we are still seeing upwards of 40,000 new HIV infections every year. And that's been steady for the last few years. And if you look at how many of those young people, how many of those people who are getting infected every year are young people, a third of them are in their 20s or teens. And so it's really important to be focusing on this. And in particular, my interest is in vulnerable young people. And so if you look at the new HIV rates or cases, you're going to find that most of them are going to be African American. Almost half of new HIV infections are among African Americans, although, as we know, African Americans only make up about 13% of the population. So it's a huge health disparity that needs to be addressed. Now, there's been a number of interventions and work over the last 20 years around HIV prevention, and there's been some successes. And if you go to the CDC's website, they kind of have a lot of these programs available, and they need trainings, and they're doing more dissemination and diffusing these programs. However, like many other health conditions, we're finding that the infiltration of evidence-based practice is not where we'd like it to be. And so these evidence-based interventions actually have a very limited reach, ultimately. And there's a number of reasons why the reach is so limited. They're very expensive programs. Most of the, if you look at the programs that have been found to be effective, most of them are going to be multi-session, requiring highly trained people who have at least a master's education. Oftentimes they're happening in small groups, so that requires just a lot of coordination, getting people together. And if you've ever worked at like a community-based agency or a medical clinic or any place that's really dealing with vulnerable populations and all that goes along with that, things like staff turnover is high, training costs begin to go high, and so there's a lot of reasons why, although these interventions have been proven to be very successful, we're seeing the actual implementation of them in real-world settings to be not where we'd like them to be. And as an example, so I've been involved in a number of these interventions, and so one of the interventions for runaway and homeless youth that I worked on was 10 sessions long. We're talking about runaway and homeless youth. So they're a very transient population, yet, you know, the intervention that we have, if we can get them to come for 10 sessions, really works. But can we get them to come for 10 sessions, right? And if you go to an agency and train folks, and I've done this on how to do the intervention, you're training like every 3 to 6 months because the staff turnover is just that great. And then when I do the training on this intervention, it's a 40-hour training, right? So what agency is going to have the time to give up their staff for a week to train on one program, given all the things that particular agency has to deal with? So again, there's a lot of barriers. So the reality is, our interventions are like, I like to think of them as a PlayStation or an Xbox. Lots of buttons, very complicated, a lot of work to do. And this is where I'm dating myself. And what we need are interventions that are very, very simple, right? And that can be easily implemented. And for you younger folks, this is an Atari controller. Before PlayStation and all of that, we basically had a stick and a button. And that's how we played. And so that's kind of where we need to be going. We need to be building programs that are going to be easily implementable, that don't require a lot of additional work. And that's really where technology can come in. And so this slide is like a couple of years old now, so I'm sure if I found a new one, it would just be even more compact and dense. But basically the whole point is that the way young people are communicating these days is very different than the way we've communicated in the past. And it's ever changing. So probably 2 years from now, it would be very different than what I'd be talking about today. Because I'm learning about all kinds of new apps and new websites and stuff that young people go to all the time. So we really need to be thinking about how we are trying to talk to young people. Because the reality is, so that young people talk to each other through these technologies and through social media, much more than they do in person. Right? And so for someone like me, something like email is a tool. Right? Technology is a tool that I use to get my work done. Whereas for many of these young people, technology and these tools, what I consider to be tools, really are part of who they are. It's part of how they represent themselves, it's part of their identity. And so it's really integrated into their everyday lives, which is why it's so important for us to really be considering these. So if you look at how young people communicate with each other, this slide's actually a few years old now as well. As you can see, Text messaging is the #1 way that young people communicate with each other, or communicate in general, not even just with each other. If you ask them how they like to talk to someone else, text messaging is #1. And kind of what we're seeing changing over time is email. Even email, which used to be the way everyone did everything, is now something that young people don't engage in very much at all. So the dark blue bars are the things that they really have preferences. So things like talking on the phone, all of that kind of stuff is changing. This is a few years old, so I would imagine that social network sites are probably a little bit higher now than what you're seeing here. So the real question then becomes, if we're doing prevention with young people, what do we need to do in order to get them to listen to our messages? How do we engage them in the prevention kind of work that needs to happen? And will they attend, like what we've done in the past is we have therapy, we have groups, we sit around and we want to talk and converse, and is that really what we need to be doing these days? And that's partially what's driven this body of work that I'm going to talk about today. So let me start. So I'm going to talk about a couple of different technology, I'll say tools because I'm old. So one is the internet and computers, right? So if you look at young people's internet use, it's ubiquitous, right? It's just like all the young people are using the internet. And I did a study a couple of years ago with runaway and homeless youth, and we did it on the internet. And the reason why we did that intervention on the internet is when we did some previous work with these young people, and this was, gosh, early 2000s. We asked these homeless and runaway youth how they got information, where they were going, how they connected with each other, and one of the things that they told, they all, like 78% of them had an email address. And this was in the year 2000. So although they were transient, they didn't have a home or stable housing, so they were able to get online on a regular basis. So there's been much discussion around even kind of the digital divide around online access, internet access among different groups of young people. And the reality is, so some of the data is now showing, in my own personal experience to show, that young people find a way, right? So some of the poorest young people may not have a computer with the DSL connection at home, but they have a way to get high-speed internet. And these days, oftentimes, that's going to be using a smartphone. So, so this was done back in 2011, a survey with young people. We've asked them what they use the internet on, basically computers, their cell phones, and more kind of game consoles like the Xbox and PlayStations and those kinds of things. And so there's a lot of advantages to using computers as a way of connecting with young people and providing prevention information. It addresses many of those challenges that I talked about earlier around evidence-based interventions, including that they're accessible, that they're much more cost-effective, that you talk about fidelity and implementation, it's much easier. But the thing that I think is most important is that oftentimes they work almost just as well as doing it in person, face-to-face kind of thing. And so, you know, and I'm not going to suggest that doing something online is always better than doing something face-to-face. I am a psychologist after all. And so there is some power to sitting down with folks and having a conversation, but it's not always necessary. So let me tell you about one study that I did where we worked with young people who were in continuation school. So these were young people that were very vulnerable, bad grades, using drugs, interfacing with the juvenile justice system, and having sex, and mostly young people of color. And so what we did is we took an intervention that had been used in it was a typical traditional small group intervention where you bring people together, you have conversations, you do skill building activities, you address whatever their barriers are, you think about attitudes and try to turn around some of those in order to get a young person to do something that's more healthy. And in this case, it would be using condoms more often. So what we did was we took that in-person intervention and we converted it. I won't say converted it because it's not exactly the same, but we basically did a computer version of this intervention and tested it out. So let me show you a demo of one piece of the intervention. So this happens in probably the third sitting of the intervention. And the young people have gone, the students have gone through some sessions on what are the antecedents to risk behavior, because of course if you ask a young person, well, why'd you do that? Most of the times you're going to get, it just happened, right? So like you have to talk about like what is it that happened, where your opportunities for doing something differently are. And this particular activity is intended to help young people see that there are attitudes that they have and that their friends have or that they perceive their friends have that make it difficult to practice safer sex. So I'm going to pretend that I'll pick this guy. So this, basically there was already an intro that played and you're supposed to pick what character you want to interface with.
Holla at your boy. We don't always talk about sex because we got assumptions about how people should act. These assumptions create a wall between you and your partner. We call these assumptions unwritten rules. Use the spray can to reveal some unwritten rules. Grab the spray can with your mouse and hold down to drag. Press the S button down to spray the wall. Keep spraying until you find the rule.
I don't think I don't trust him if I ask him to use a condom.
Good. Find another.
I don't need to use condoms with someone I've been with for a while.
If she has to use a condom, she must have a disease. Messing with a condom interrupts my flow. I lose my chance. Good. You gotta bust through those rules to be safe. The way to bust through is to talk about being safe. There's 3 ways to come at your partner: assertive, aggressive, and passive. Click to find out about different ways to talk. Click on the hammer to grab it. Press S to hit the target and try and break it down. You busted and disgusted, I'm out, y'all. When you use aggressive talk, you just come right out with it, not caring what the other person thinks. You ask for what you want, but you show no respect for your partner's feelings or ideas. You might. Try another one.
All right, so you get the point. So basically we're teaching them different ways in which to talk in order to negotiate condom sex, safer sex. And then there's more going on. There's more, but basically that's the idea. Okay. So, yeah, I'll just do the one demo. So one of the things that we found, so one of the big questions is, will they do it, right? So that was the first question. And so what this slide is intended to show was that, so we randomized schools. There was a school that got the small group version of the intervention, the school that got this computerized version of the intervention, and a school that didn't receive anything, so they were our control group. And one thing I think is really important is that the beauty of using technology is that you're much more likely to reach the number of young people that you'd like to reach. So if you look at the computer versus the small group, the young people who are randomized to the computer, we were much more likely, most of the kids got the full dosage of the intervention, all of the sessions. Whereas the small group, we only had 3 kids who actually did all 7 sessions. And now mind you, we did this intervention, we brought pizza, we made sure not to do the intervention on a Monday or a Friday where the kids were going to ditch. Yeah, we did a lot of stuff to make sure that the kids were there. And the reality is, if the kid was there, they came, but the kid wasn't at school every day. And so we weren't able to capture as many young people. And so so the technology really allowed us to get the full dosage, or at least some of the intervention, to the young people, much more than the small group intervention did. And so, okay, so they came, but the question is, did it work? And so what these slides show is that what we found is that if you looked at The number of sexual partners, you would expect over time, of course, that there'd be more opportunities and the numbers would increase. So that red line is the control group. So over time, the number of sexual partners increased. Whereas in the small group in the computerized intervention, those decreased. And that was a significant difference. So that's great. The thing that I think is also really interesting is that if you looked at the percent who had sex or reported having sex, the computerized intervention, although they started off obviously more risky, we saw a significant decrease, whereas in the other two groups, we saw a slight increase. So in fact, the computerized intervention did better than the small group intervention in helping the young people to reduce the times that they were having sex. And that was a significant difference.
Why at baseline are they different?
It's because it's at the schools. For whatever reason, the schools were different.
Oh, I see.
Yeah, so we didn't randomize by individual, we randomized by the school. And I have no idea why one school is more risky than the others. And then when you look at, and when you look at whether or not they had unprotected sex, this is not significantly different, but you can see where the trends are, right? So the intervention actually did just as well and sometimes better than the in-person intervention, partially because we were able to get more dosage to the kids. But the other thing that's really interesting is that we also found that the young people in the computerized intervention did sessions more, they did stuff that we didn't ask them to do, right? So everyone who did the intervention, they got health credit for their health class. But they weren't getting any more credit by doing the sessions more than once. But the computerized intervention, the young people were doing some of the activities over and over again because they thought they were fun and interesting. I can't get a kid to come to a group more than one time, especially a structured intervention where we're going to be doing the same thing in a particular session. They're not going to repeat a session. But for the computer stuff, they were really into it. And so this is one example of a growing body of literature that really suggests that e-health interventions using computers can be successful for HIV prevention. And so what we've seen is using these interventions have increased knowledge, they've improved the attitudes, self-efficacy, and beliefs that influence health behaviors, they reduce risky sexual behaviors, and there's also been biological outcomes where we're seeing STI outcomes being better for young people who have experienced these e-health interventions. So these seem to be a potential way in order to get to young people. The other thing is...
And Marguerite, the denominator in that was, I mean, what was the denominator? Was it an intent to treat analysis?
It was an intent to treat analysis.
So I mean, what proportion of the denominator used I know that more people use the computer than the in-person, but what proportion of the denominator more or less?
So in the computerized intervention, it was about 85%.
Okay, got it.
And in the
in-person.
In the in-person, it was like 10% of the kids got all of it, and about 50% got some of it.
Yeah.
I could imagine people critiquing this as regression to the mean because the computer group started out higher risk. Do you have a...
Potentially. I mean, we were controlled for that baseline difference and still found the significance over time.
Is that right?
Yeah.
Okay, so that terrific. And did you do any qualitative? Did you have a chance to do any qualitative work to see if that felt like the right thing, it felt true to you?
So we did do some work with the young people just to get their reactions to the intervention and stuff. And then with the small group intervention, just why we weren't able to reach the kids. And there's a whole host of reasons why the young people were not at school every day.
Yeah.
And that was really the reason why we weren't able to reach the young people with the in-person intervention. In terms of the computerized intervention, most of what they said was that it was fun. It was an interesting way to get the information. They would talk about it with their friends. We talked with the teachers as well. Actually, one of the things that was initially a little bit of an issue is that it was, so the young people did the intervention in the back of the classroom when they finished whatever schoolwork they had, or the teacher basically navigated it. And initially, so the teacher realized that there needed to be some more controls because the kids in the back of the room were being disrupted, right? So they'd be laughing, or they'd be trying to get their friends to come and look at it. And so we found we had to work with the teacher because they began to be upset by it being a disruptive thing. So we had to work with the teachers to get them to help problem solve how to navigate and manage it. So I think, so for the young people's perspective, it was just a different way to get information. It was interesting. It was fun.
Do you think they would have used it if it was accessible outside of the school?
Probably. I mean, all I can, there's a lot of competing issues, and clearly this is not as in-depth or as an Xbox game or something like that, right? The graphics just aren't as great. But what we did learn is the kids are wanting this kind of information, right? And there's not a lot of places they can go to have this information in a way that they feel comfortable with. It's just off their friends. And even when they talk to their friends, they're listening to their friends, but they're telling us that they're not always believing what they realize that their friends aren't the best people to go to for this kind of information. So I think there's definitely the possibility they would do it outside of school, just because I think they want to know the information. So let me move to another project that I've been working on, and that's using text messaging and cell phones. And so I know I'm speaking to the choir, given all of you are using some or interested in technology, but cell phone usage obviously is just, every young person has a cell phone, right? I mean, I have a 14-year-old son, and in 3rd grade is when he first started asking for a cell phone. And 4th grade is when it was like really getting full court press, nagging for the cell phone, and in 5th grade is when his parents gave in and gave him the cell phone. But by 5th grade, almost all of his friends, like 70% of his friends, had cell phones already. And so that's like 11 years old, right? And so my experience is the experience of most parents, and definitely the experience of, in the United States, cell phone usage. Young people have cell phones. There's been concerns around the cost of cell phones, and all of, you all probably have a good understanding of just the availability of cell phones, the affordability of cell phones. Some of the differences is about whether or not young people have a smartphone versus just a regular like an SMS type phone. But regardless, young people are texting and they're on their phones regularly. In fact, if you look at how often a young person texts, they're texting a lot. So 31% of young people send over 100 text messages a day. A third of young people are sending that volume of text message. And plans today, it's unlimited text messaging, right? Because every parent has had that, almost every parent has had that experience of having a limited text plan and having that go way off the chart in terms of going overages because young people are just texting all the time. And it doesn't matter if you're a boy or a girl, it doesn't matter if you're a young preteen or adolescent, texting is a huge thing. And I find that we all are probably texting a lot, and young people are no different than us. And most young people these days have an unlimited texting plan. This is a couple of years ago, so it's probably even more so now because it's pretty cheap. So this is kind of, I think, typifies young people today. They hate having to talk on the phone. Although my mother tells me, last Christmas I went to take my mother to go and get a texting cell phone because she still has a flip phone. And the reason she asked me to go and do that because she said, well, I call you and leave you a message. It takes you days to call me back. But your brother tells me he texts you and you respond right away. And that is the reality. And I think that's the experience that young people are having. So, and there have been a number of text messaging interventions out there for a whole host of health conditions. And typically the text messages are providing information, some kind of messaging that's intended to be positive and uplifting and empowering, or doing reminders. So let me tell you about an intervention that we worked on that incorporated text messaging. So it was basically a small group intervention that we augmented with text messaging with the intention of hoping to elongate the effect of the intervention by having text messages reinforce the messages of the intervention that they would have gotten in person over time. And really we were really interested in what makes sense to do in terms of texting health promotion messages to young people. Right, so the original intervention, this BART intervention, had a lot of good outcomes. That's why we used it. So it was able to reduce sexual activity, initiation of sex, and unprotected sex. Okay, so once I got the small group intervention, we did a daily text message to the young people for 3 weeks after the intervention that was intended to reinforce the messages they got in the intervention. So each of the messages related to something that happened during the intervention. We also asked a question, and that was our way of ensuring, checking in to see whether or not the young person actually read the text message, because you can't really tell, right? So we asked them a question. If they answer it, then we assume that they read the text message. And then we use the internet service to manage the doing of the text messages. So what we found was 80% of the time young people responded to us. We were assuming that 80% of those messages were seen. And when we asked young people what format, because we were doing regular SMSs, we were sending pictures, we were doing videos. Not all the young people had phones that had that capability, but we were doing it to see kind of what young people would tell us. And so they liked it if we just randomly did stuff. So they didn't care. They didn't like having like a text message every day. They liked it that we kind of mixed up the kind of message that they were getting. And we also heard that if a young person if they couldn't open the video, they would go to a friend and forward the message to the friend, and they would watch it. Not every time, but so we were pretty confident we were getting some good reach there. They also felt really good because when we asked them the question, they answered, and then we told them whether or not they got the answer correct, and if they didn't know what the correct answer was. And most of the time, actually, they were actually getting the correct answer, which is also good because they sat through that 6-session intervention. They should have remembered something. But they also reported feeling really good because they knew the answers and remembered the answers. And that, in and of itself, was the reinforcement for them to continue to look at the text messages. They liked having it just once a day. And we did have this question about, do we use like all these abbreviations or should we just use long form? And what they told us was they liked the long form because the abbreviations added confusion. And it's not, and I wasn't the one making up the abbreviations, so it was real abbreviations that they should have known. We had a youth advisory board, but the reality is they don't even know the abbreviations that they text each other. Like they're kind of making this stuff up, and so it turned out that they would rather have it long form. But this study did bring up a lot of questions, right? If you're thinking about doing a text message intervention, what kinds of things? So one is, when do you send the text message? And so for our study, the kids didn't care. They had the phones with them all the time. And so we could have probably texted them at 2 in the morning and they would have responded. The other one was to use video or not to use video. What we found in our study is that about half of the kids didn't have a video capable phone, but they liked the option. So even though that they couldn't open the message, they liked that they had the option to try to get, figure out a way to open the messages they wanted. So they actually preferred us sending them video messages, even though they may not have had the phone that did it. The third thing was really interaction. So what we really learned is that the young people liked the interaction on the text messaging. So not just that we sent the message, but then we asked the question really as our own personal motivation was just to make sure that they read the message. But for them, they perceived it as that we were trying to interact with them, and they liked that much more than just this one-way communication. They liked giving us some information. Initially, when we did this intervention, this was a few years ago, we had this whole question about, well, do we give out the phones to the kids, or do we let the kids use their own phones? And partly that was because we were worried about other people reading the messages, their confidentiality. Although there weren't targeted messages, the messages did talk about sex, because if you're going to talk about condoms, and HIV, you got to talk about sex. And so we were some concerns about that, and then also just whether or not what the cost would be to the participant for having text messages come in, particularly if we were doing videos. And what we came down, so initially we were going to be giving them phones, so that they had this phone that they only use. But the feedback that we got was they wanted to just have one phone, that most of them were unlimited text message plans anyway, and they were not worried at all about people reading what was on their phone. Because the reality was, they have a whole lot worse stuff on their phones than what we were texting them. So
the unlimited text message plans will accommodate a video?
Yeah,
at no cost?
MMS, yeah. Most unlimited messaging plans include all kinds of messaging.
And the fidelity of the video is sufficient to
Typically.
Convey, yeah.
Yeah, I mean, we did have a little bit of trouble that had to do with a particular carrier.
Mm-hmm.
And so those things I think probably, but we were able to work it out. And then that's the next line's all about the abbreviation thing. Like, it used to be LOL, now it's LMAO, now it's RL, I just can't keep up with all this stuff, and neither can they. And then there was the question about what should we do if they don't respond. And what they told us was it's okay to text message us again. Now, there's literature that suggests that within 12 seconds, most young people will look at their text message. So it really isn't it really isn't an issue of whether or not they've seen the message, because if you text it to them, it's more than likely that they've seen it. But if they didn't respond, so it's this whole responding thing for us to ensure that they saw the message. And so they were fine actually being texted again. Yes?
Did you have any struggles with the IRB in launching this study?
Surprisingly, no. And I think that was because we had a youth advisory board, and we were able to show them what the text messages were, so that they were fine kind of with the content of the messages. So they were able to, I don't think they looked at all 300 or whatever messages that we had come up with, but I'm sure that they glanced through it and they felt, okay, these messages are going to be fine. I have had issues using technology. Like there was one study, I mentioned this homeless runaway study where we were doing online interventions. We set up a website. And part of the website was Ask the Expert kind of a thing. And so the young people would ask us questions and we would respond to them. And typically they were questions, they were health questions like, what is chlamydia? Or I have this happening, what should I do? And initially what the IRB wanted was us to show them our response, to get approval for every response before we could post the response. Now, can you imagine? So I'm thinking, okay, a young person is going to post a question and then they don't get a response until a month and a half later when the IRB has approved that message. So that took a little bit of going back and forth with the IRB. Eventually they did allow us to respond to the text messages. And the argument that we made is if we were in a small group intervention and they asked us a question, we would just answer it. Like, this isn't any different than that. We also, on that website, we had set up this is back when we were set up a chat room where the young people could interact with each other. And the idea of another way to form the community of young people who are really trying to stay safe. And we ended up abandoning that issue because it was so difficult to get through the IRB.
Question, you talked about how they answered questions back through the text and they got positive feedback for that. Did you have any interaction through the texting that was any kind of revelations of their personal stuff going on? Or is that, if they'd said, I have a question that's not, what you're asking me, they didn't do that and
we
you
didn't really
do that?
have them ask, because what we asked them was like usually multiple choice.
Yeah.
Press 1 for this answer, 2 for this answer, and they pressed the number. They didn't ask us questions, actually.
Yeah.
So, but it seems like that would absolutely have been something, and I think they didn't ask the questions because it wasn't a possibility that was presented to them. And most of this was all automated, too.
Were you asked to not text during school hours, or did?
No, we didn't have any. We never texted during school hours, so they were never required to respond to us during school hours.
So you just chose?
We just chose not to do it during school hours.
And you've talked a lot about the sort of the interface and the interaction. In terms of the content, was this at all youth generated, or was it youth informed, or was it?
Yeah, so we generated the messages in conjunction with our youth advisors. So and I haven't mentioned this, but all of this work is really in collaboration and partnership with youth.
So could you, maybe we're going to get to it, but like an example of one of the questions. Would it be, chlamydia is the name of a movie, a sexually transmitted disease, or a new haircut?
Name of a
Yeah,
movie star.
I mean, it's in that.
It's like that.
It's like that.
Okay, B for
Yeah. Or assertive talk is
better than aggressive
better,
talk.
Yeah. Well, which one of these is the best way to talk to someone? Assertive, passive, aggressive. Okay. So now we also use text messaging as a way of helping young people with testing, or intending to get them to get tested. So as you all know, getting young people to come to the doctors is one of the hardest things in the world. And so getting young people to test for HIV or any other STI is also one of the hardest things in the world. However, it's really, really important because, as I mentioned, in the United States, a third of new infections are among young people. But if you look at, there's also estimates about the number of young people who are living with HIV and don't know it because they haven't been tested. And that number's been estimated by the CDC to be around 60%. And we also know that the ones who are the least likely to use a condom, the most likely to have sex, are the least likely to have been tested as well. So we're really trying to figure out how do we get young people tested. And so one of the interventions that we're currently actually announcing right now is in partnership with the 3rd Street Youth Center and Clinic here in San Francisco. And so what we're asking the young people to do is, maybe I will do this. So we're asking young people to text message their friends and tell them to come in and get tested. And we're not telling the young people at all what to say. We're just telling them when they're coming in for their own doctor appointment, hey, will you text message your friends and tell them to come in too? And so what we were so we did a small pilot test to see if this was even acceptable. If we asked the patients to do this, would they actually really do this? And so what we found out was that the patients actually were fine with doing it. They thought it was a good idea, they thought it was important, they thought it was appropriate. We were worried about, we asked them, well, what were you worried about when we asked you to send out these text messages? And one thing that they did come up with was, well, what will my friends say? And there were questions about, well, who should I send text messages to and what do I say? They wanted a little bit more guidance than what we gave them because we just said, get your friend to come in. And so as a result of this, we're now doing a trial where we came up with a text message guide. It's not instructions, it doesn't tell them what to say, but it does help them think about the things that they need to consider when sending out the text messages and some things to say. So when we asked the young people in this small pilot, well, how did you decide who you wanted to text message? We found that a lot of them just texted everyone in their contact list, and they sent kind of one general message to all of their friends. We had some young people who did pick out some folks that they thought were important because they knew that they were having sex or suspected that somebody was cheating on them or whatever, and they sent them a more targeted message. But we did have some young people say, well, I wasn't quite sure what to say. So that's why we came up with the guide. But there were some other issues that came up as we were going through NIH review, as we were going through IRB, the CHR, and with our external advisory scientific, or DSMB, came up with some issues as well, and things that we were already thinking of. And so some of the things so I'm sharing this is because there could be things that you all that you would want to consider as well. So one thing that came up, mostly with the adults, really was, well, they were afraid that the kids would be, that the recipient of the message would feel bullied because you're saying, oh, you need to go and get tested. And so one of the things that we did to try to allay that, and this is not a fear that we went back to the kids and they're like, what? We text fresh and stuff all the time. They were like, this is not it. But we wanted to make sure that in the event that it is an issue that we have some things in place. So one thing that we're currently doing is that before the young person sends the text message, they show the message to the research assistant. So the research assistant can say, are you sure you want to send that? I'm wondering, and kind of make sure that it doesn't sound too bad. And we're also following up with every kid who sends the text message. A week later, we go back to them and ask them, so how did it go? Have you heard anything from your friends? We try to offer any assistance if, in fact, that they're finding that it's caused some friction between them and a friend, that we can help to mitigate that some. There was a question of whether or not we should offer incentives. Should we give the kids money for sending out text messages? What should we be doing? And so, particularly since we know that the texts themselves don't cost money. Once they send out the text message, we do ask them to also to complete a survey for us and give us some information, because all the data is anonymous to us. And so what we do is we give them an incentive for filling out the questionnaire, but we don't give them necessarily the incentive for the text messaging. And kind of anecdotally, what we're finding is the kids are like, and we're giving them $10. And what we're finding is that after they text, they send the thing and they give the $10, they're like, oh, you're paying me for this? You didn't have to pay me for this. Mm-hmm. So it's kind of like it was really, for them, to me, it sounds like it's really not that big a deal. And that's what we heard in our smaller pilot study as well. one of the things we really grappled with is whether or not we should have standardized messages. And so shouldn't we come up with some theory-informed message that's, of course, we work with as in the other study, we work with young people to come up with the messages, but ultimately we come up with the message and we tell them what to send. And we decided against that because really what we're interested in is, my assumption is the kids are going to be the most persuasive of their friends. They're going to know a whole lot better than I am what to tell their friend in order to get them to come in. So we actually are capturing every text message that the young people send, so that we're able to kind of see, and we'll be able to do some qualitative analysis on the kinds of messages the kids are sending. But we're not telling them what to send.
Can I just ask you how you actually capture that? Is that when the research assistant is with them and they're sending?
No,
that?
we ask them to send us the message too. So the study has a phone. So they send the message to their friend, and then they send that same exact message to us. And they don't do it as a group message, because if they did that, then we
You'd
as
see
a study would
everything,
have
yeah.
their friends' contact information, which we wouldn't allow them to have. Now, what we don't know in the study is whether or not the kids read the message. And then, and this quote is something that was straight off of my summary sheet. So this is just me being sour grapes. I just like to, it just makes me mad every time I read it. So on my summary sheet for this study, it says, one person says, if they're already in contact, why send an impersonal text when actual word of mouth is possible? Right, so, so after I cooled off, I responded to that in my resubmission of this grant. And obviously it got those, they were not too upset about it. So the outcome of this study is really we're looking to see whether or not we're able to reach more high-risk kids by working through the peer networks, right? So currently what clinics do is they either wait for patients to come in, or they do have outreach programs at like schools or something like that. But we're seeing if ultimately what we're really trying to do with this is see if, in fact, by doing this, we're getting the kids who are most at risk to come in. So we'll be looking at the metrics of all of the clinic patients as they come in. So one of the things that we did when we started working with this clinic is we built them a server, and we put their intake electronically, and they bought iPads, and we programmed everything for them. So now all of their data collection is electronic on their intake. So previously it was a paper and pencil intake, and then they'd have an AmeriCorps volunteer input the data into an Excel file. So it was a win-win on both sides. But this is allowing us now to see, for all new patients coming in, what are the risk behaviors they're reporting, and is that changing over time as a result of these text messages? Okay, so this is just the design of the study. So we're basically collecting data on STI testing at the clinic and outcomes, the sexual risk behavior of new patients, and the volume, clinic volume outcomes. So how many patients are coming in, how many new appointments. We're doing the text messaging, and then we're continuing to look at those metrics to see if they change over time. And then we'll be asking the young people. We're getting feedback from both the providers and the youth.
And again, your target population is who? How do you define your
Our target population is patients who, adolescent medicine clinic patients. So this
adolescent medicine
serves,
clinic, irrespective of whether they're coming in for STIs, whatever,
Yeah,
and assuming that they have a whole bunch of friends.
Right.
Got it.
Right. So the clinic serves 13 to 23-year-olds, and so it's basically all new patients that come in the door.
Cool.
So stay tuned for the results of this. We don't know yet. It's actually currently being implemented.
So that's a pre-post design.
Yeah.
There's okay.
It's being funded by NIDA. And so text message interventions have been successful. So I'm telling you a little bit about my study. I haven't been able to tell you the outcomes yet. However, we do know that we've seen increases in knowledge, fewer sexual partners, and changes in lifestyle behaviors as a result of text message interventions, so that they work. So basically, they're highly acceptable, they're feasible, although they challenge us, all of these technologies, and I think it challenges us to think in a different way, but I say let's go with it and let's get on with it. The last kind of intervention I want to talk with you about is video games. And so there's a lot of data that's really emerging now that shows that video games in that environment is a really powerful space to help young people to learn, to change their attitudes, to really engage in kind of health promotion behavior. And they're using video games for a whole host of different health conditions, right? So diabetes, cancer education, obesity, exercise, all kinds of things. And so we're seeing a lot of positive outcomes. So I'll tell you a little bit about one of the video games that I've developed and worked on. And this video game was intended to help young people learn to regulate their emotions, with the kind of the underlying assumption being that partially the reason why young people are risky is because they're dealing with, it's their way of coping and dealing with the emotions that they're feeling. And so if we can help them to do that in a more healthy way, to deal with the really strong emotions, then they're much more capable of making better decisions. So we implemented this video game in a few high schools in Los Angeles. And again, the target was kind of these physiological processes. I'll show you a video. I now show a video because I used to demonstrate the game, but I'm really not very good at it. So I'll show the video instead, and we'll get a sense of what it's like.
Take your time.
This is not coming out. Let's do it this way. You get the point. The interesting kind of stuff. So you get the point. So basically, it's like a first-person shooter game, right? So you go in a first-person shooter game, you'd learn how to use the guns and jump out of the holes and all of that kind of stuff. And then you'd go play the game where you're actually shooting the other guys. And so this is the whole point. There's these different rooms that teach you different emotional regulation skills. And then once you learn the skill, you go into a game interaction that's intended to increase your heart rate. And your ability to be successful is dependent on your ability to control your heart rate and your physiological response in the game. And so one of the things, so again, we're just piloting this. And what we found is that over what the pre-post found, so we did a baseline, kids played the game for as much as they wanted. We just had it available at the school for a month, and then we followed them 3 months later to see what they reported. And so what we found was that they were better able to access kind of emotional regulation strategies. And psychoticism is really kind of having an aggressive reaction to stimuli. And so what we found is that young people were reporting a lower aggressive response. And so kind of it's also related to impulsivity and sensation seeking. So they were like basically saying they're better able to deal with impulses and sensation seeking. So that's kind of some of the short-term outcomes that we found from using that particular game. And this very busy slide basically says that the kids liked it. And they would tell their friends about it, and they really enjoyed engaging with the game. So with that, let me just summarize. Am I saying that we need to stop talking to kids and sitting down with them? Absolutely not. But what I am, do we get rid of these interventions? No. But what I am saying is that not all kids need that, and that you have a much greater reach and reach more kids by using technology. And for many kids, that's all that they need in order to make the behavior changes that we want to see. Okay. So let me just end with a video that I think kind of summarizes this whole issue around whether or not we should be using technology for young people. This is probably not gonna work, but
Oh, it's an-
What's that video called?
it's called Social Media Revolution. Take it over your room. And if you want, I can send, if you email me, I'll send you the link. So to end with, let me just thank all the folks who funded my research, as well as the young people who allowed me into their lives. So I'd happy to answer any last questions that you all